Fortunately, disasters in the US haven't been associated with large outbreaks of communicable disease. But I think there are a lot of emerging and re-emerging threats that we're starting to see both in morbidity and mortality related to disasters. So I'm going to try and talk about some of those today. So just to sort of start with what the language that we use around disasters and emergencies can be very different. And we can kind of think, and so I'm sure as you think about maybe activating a hospital emergency plan or what would constitute a disaster within your family or community or other organization, you may have a different idea. But I mean, an emergency is something that we're more familiar with when we suspend our normal procedures with actions that we've planned for and typically exercise to prevent a disaster. And then that becomes a disaster when the resources of the local community are exceeded and we can't take measures to avoid that anymore. And there's a lot of people who've been working in the disaster research community who are trying very hard to get people to stop talking about natural disasters and to think more about the ways in which things move from an emergency to a disaster, in part because of the way that communities are resourced and structured. And so something that may, be easily dealt with as an emergency in many places will inevitably become a disaster in others. So I think that probably everyone is aware that we are having more frequent and severe disasters in just about any way that we would like to measure them. As Kate mentioned, I've done a lot of hurricane response, and flooding. So I tend to like to think about them in terms of hurricanes. So we've had 4 of the wettest tropical cyclones on record to impact the United States in the last 5 years. And you can see those there in terms of the amount of precipitation associated with those storms. And so we are just having bigger, stronger, more frequent, and more severe disasters. And that's why I think it's so important to raise awareness around these ideas of disaster morbidity and mortality, because we're going to see more of it. So there are other reasons beyond the increase in frequency and severity of disasters that we're concerned about this from a population health lens. And in part, that's this idea of compound or cascading or complex disasters. And those all mean something slightly different, but somewhat related. Either disasters that are occurring at the same time. So we've had close to 200 major disaster declarations in the United States for climatic disasters like tornadoes or floods or hurricanes, while we have also had the public health emergency disaster declaration for the COVID-19 pandemic. So all of those are inherently concurrent disasters. But in addition to that, we have an aging population. So more people who have limitations with regard to durable medical needs or limited transportation and other sorts of complex chronic conditions that could be exacerbated by a disaster. Globally, we have urbanization, with most people now living in really small areas at high risk. So if we look at the impacts of Hurricane Ian, we can see, sort of a little microcosm of that in terms of really dense communities along the Florida Gulf Coast being really severely impacted. And of course, climate change is changing both the type, frequency, and severity of disasters that we'll be facing. And so one way of thinking about this that's talked about a lot is this idea of billion-dollar disasters. And I'll talk about that a little bit more, but in the next slide. So I mentioned in the previous slide that there's sort of new kinds of things that we might be thinking about. And so, heat waves, if we compare someone born in 1960 to someone born in 2020, they're going to experience about 8 times as many heat waves over the course of their life. So the risk of a health impact from that is going to increase. Wildfires, floods, droughts. So considering both acute and the more slow onset disasters. So again, risk is increasing, and thus our awareness of the health impacts of disasters really needs to increase. And so I mentioned that one way that people frequently talk about disasters is this idea of the billion-dollar disaster. And if you Google billion-dollar disasters, you'll find lots of great charts, showing this increased curve going up over time. In 2022, we've had 15 weather and climate disasters that exceeded $1 billion. This was the 8th consecutive year that the United States had more than 10 billion-dollar disasters. But as I mentioned before, that focus on cost can actually distract from the need to think about equity. So it's easier in a sense to get to $1 billion if a storm impacts a population dense area with a lot of expensive infrastructure. Whereas devastating flooding in rural Kentucky that happened in the past few months is, going to be hard to get to $1 billion, but is tremendously impactful relative to the population in terms of the number of homes destroyed and the morbidity and mortality. So I think it's important to remember that the dollar figure is just one way of thinking about disasters. So we have a lot of evidence. We've known this for a long time in the disaster studies world that disaster impacts are inequitable. So this is just one example of this. This is Houston, that sort of white big blob there is Galveston Bay and the surrounding counties in the Houston metropolitan area. And so this is just a map showing the extent of flooding and the proportion of non-Hispanic, Black, Hispanic, and people living in poverty in those census tracts. And so what we see is that there's a strong spatial correspondence between racial and ethnic minority and poverty and the extent to which a census tract is flooded. And so that's a more sort of general way of thinking about this, and we can look at that in a number of instances. So we don't have to go to Houston. We saw this right here in Wilmington last fall when Hurricane Ida impacted the community. We saw poor neighborhoods impacted in Wilmington last September. They can have more disaster impacts and less resources to recover. And again, that's another point about that idea of only talking about disasters in terms of dollar amounts. And so I think that there is, certainly there has been and continues to be this thought that we need to focus on environmental justice as a part of disaster preparedness. Although this, certainly came up as a controversy after Hurricane Ian. And so I know that I'm not going to talk much about COVID, but I think that some of the things that have happened with COVID have also in the disaster community and those who are, sort of viewing a public health emergency lens on the pandemic are thinking about how the inequities highlighted by the pandemic can serve as lessons learned in planning for future public health emergencies and other types of disaster response. So I'm sure everyone is familiar with this table. This is actually several months old. It's back from February 2022, but the message has not changed much over the course of the pandemic. In terms of the risk of infection, it's not dramatically different, but in terms of hospitalization and death, race and ethnicity are those of American Indian, Alaska Native, Black and Hispanic persons have a much greater risk of hospitalization and death. And so we actually saw some really cool data come out in MMWR just a couple of weeks ago. So, we know that, which I think really drills down into this. And I know that there's definitely, COVID is a relatively unique type of disaster or public health emergency. But again, I think if we can focus on some of the lessons learned that are really, really important to apply to a more typical type of emergency or disaster that we might be facing. So even though we have, real world evidence that Paxlovid is effective at preventing hospitalization, we know based on this MMWR that for the last several months in 2022, that Black and Hispanic patients were, about 30%, 36% less likely to be prescribed Paxlovid. And so I think this is a little bit of a finer point on the, the idea of severe disease. And it's something that should be addressable and could be an example of the way that we can make emergency and disaster response more equitable. So the way that we try and understand the health impacts of disasters, including, chronic disease, injury, and communicable disease, is really just bread and butter epidemiology, which is public health surveillance. And so that can be as simple as just looking at counts and rates of morbidity and mortality. So this is the distribution of mortality in the US from Hurricane Ida, again, the hurricane that impacted Delaware last fall. We did not have any deaths, at least according to direct or indirect, according to these data, but you can see there the counts are pretty dramatic, and you also see this distribution of the largest number being in Louisiana at landfall, which makes sense, but then also in New York and New Jersey, which seems, is a long way from landfall. So there are different types of risks that we have to think about. So really more surveillance of morbidity and mortality is still the bread and butter of disaster epidemiology. There's also shelter surveillance. So that's particularly concerned with communicable diseases, diarrheal and respiratory that we expect to see when we have crowded conditions that sometimes tend to happen in evacuation shelters. Although, potentially the pandemic has changed the way that we will do sheltering in the future, with more people getting vouchers to stay in hotels with their immediate family group and fewer people using large congregate shelters like sports stadiums and other approaches that have been the norm up until now. And what we're looking for in that surveillance beyond just situational awareness is a way to evaluate the public health impact of any sorts of interventions that we may have done. So maybe we've had a disaster and implemented a new plan for those who have end-stage renal disease to receive dialysis after an emergency, and we want to see if it worked. Did we have more people with end-stage renal disease showing up at the emergency room, or did we have fewer compared to previous storms? And that can also provide data for analytic studies. And so as may be obvious at this point, this is really difficult because no disaster is the same. Different types, different temporal and spatial locations make it really difficult to apply something learned from one disaster to the other. And that's what's really hard when we think about the public health and clinical impacts of a disaster, is that we're not going to see exactly the same event in exactly the same place. So we still have major challenges in defining disaster-related deaths. this concept of what's a direct death and what's an indirect death remains a challenge. Reporting also remains a challenge. We have this often used trope about if you've seen one local health department, you've seen one local health department, and you could pretty much say the same thing about how death reporting is handled in counties and states across the US. If you've seen, the way it's done in one place, you've seen the way it's done in one place. So capturing death information in a timely manner post-disaster can be a real challenge. And that's where we end up with these kinds of things. Like I just took a screenshot one day of the, mortality associated with Hurricane Ian, and we have 14, 34, 83. So that is changing, and you can see that the source for all of those data are the news media. So immediately following a storm, we don't typically have access to vital records type data because, as everyone knows, that takes a lot of time or a good bit of time. And so we're really relying in large part for some of this morbidity and mortality information to come in from the news media. And so you can see that here as well. So when we think about morbidity after disaster, the main sorts of things that we think about are outbreak investigations, emerging and re-emerging diseases. So more public health departments are doing trapping and testing of mosquitoes for Zika, for instance, after hurricanes and flooding. A greater focus on mental health outcomes associated with disaster, with a focus on the prevalence of more severe disorders after disaster. All kinds of things that maybe wouldn't necessarily think about, but might be rolling into the emergency room. So my first hurricane that I worked on back when we still used to fax things was Hurricane Floyd in North Carolina. So we were getting emergency department data faxed into the state health department each day from around 33 facilities in the impacted area. And so domestic animal bites and spider bites and things like this were actually something that we're seeing quite a lot of. Other more things that are maybe more typically dealt with in a social services infrastructure than a health services infrastructure, like domestic violence and assault. We definitely see increases in all types of disaster settings, and lots of research on that in everything from tsunamis to tornadoes to COVID, of course, and others. And so you see, though, that a lot of these data initially are coming from media reports. So, this is something about the increase in the number of people going to urgent care after Hurricane Ian. And so again, it's difficult from a public health perspective, to know quickly what the burden of disease is. Is much more anecdotal, at least initially. So there are ways that we can think about preventing communicable disease in the wake of a disaster. And those tend to be, really straightforward, but perhaps important to remember. In part, knowing what diseases are common in the impacted areas. So a tsunami in Indonesia will be very different than a hurricane in Florida. Understanding the living conditions of the affected populations and access to safe food and water. So there are many health conditions obviously associated with access to safe and healthy food and water. And so knowing about boil water advisories, or whether or not water treatment facilities have been flooded or gone offline, it can be very important. And underlying health status of the community that is impacted can be very important. whether that is nutrition or immunization coverage. I'm going to talk a little bit about how immunization coverage has really come to the fore recently with our case of polio in Rockland County, New York. And what is the access to healthcare? So are people, able to go to urgent care or emergency rooms? Are they, going to field hospitals like we had people doing after Hurricane Katrina? And so I think just sort of that increase in situational awareness in the healthcare and sort of the frontline patient-facing healthcare workforce can really help us prevent these most common types of morbidity that we see post-disaster. And so those are, food and waterborne outbreaks, those diarrheal and respiratory outbreaks associated with crowding in places like shelters, vector-borne diseases. So obviously dependent on the place that we are in the world, but also thinking about the risk of emerging and re-emerging diseases. And then also fungal disease that can be associated with exposures to soils, molds, and dust, which may not really be on our radar in a typical situation, particularly in a domestic setting, but could be something that would be need to be addressed in a post-disaster setting. Oops, I keep thinking I can do this with my space bar and I can't. So Hurricane Katrina was a while ago, but there was just a ton of research and publications around the surveillance. I want to give an example from that as well as from Superstorm Sandy, just to kind of give you an idea as to the scope and scale of what's happening with morbidity and mortality post-disaster, as well as sort of the public health response to that. So there were significant spikes in emergency department census after Hurricane Katrina that peaked 3 days after landfall. You can see that, in that sort of the healthcare facility data in the sort of 3 weeks after landfall, injury was a large share of the reason why people were showing up. But rash illness, respiratory illness, and gastrointestinal illness were not negligible. So in the surveillance conducted immediately following in 29 facilities of about 25,000 case reports, 16% were infectious disease, 26% were injuries, motor vehicle trauma, falls, and 33% were exacerbation of chronic illness and medication refills. So while infectious disease is not the largest share, it's not a negligible amount of people who are being impacted by communicable diseases post-disaster. So if we look at another major risk factor post-disaster, it is carbon monoxide poisoning. So this is the surveillance in Alabama and Texas after Hurricane Katrina and Rita. And so you can see those fatal, probable and confirmed cases occurring really in the immediate aftermath of landfall. And this is a place where, considering a knowledge of the risk factors that increased tremendously post-disaster can be really important from the frontline patient-facing healthcare perspective, and where population health has a really big job to do in terms of health education and interventions around preventing people from using generators incorrectly after a disaster. So I think that it can be tempting to think about, well, I don't know, for me as a disaster epidemiologist, sometimes it can be tempting to think about these sort of exciting emerging threats when we think about public health emergencies, so avian flu or Zika or Ebola. But in fact, it's more likely our good old favorites like measles and things that we most need to be concerned about in terms of thinking about communicable disease risk post-disaster. So if we look at sort of a different type of humanitarian crisis, there was a catch-up polio vaccination campaign that was started in Ukraine in February of 2022, which coincided with the beginning of the war there. And in response to a 2015 outbreak, they had increased vaccination coverage to 83% by 2019. But due to limitations in access and availability, they were down to 53% of their under ones vaccinated by October 2021. So we can think about, other types of crises that can easily happen, again, when you have these sorts of concurrent events going on. So we have a lot of interesting research going on about sort of indirect or unmeasured health impacts of disasters. These can be really difficult to classify. So if we think about, again, about Hurricane Ian, if I evacuate and then I have an accident in my car, is that death attributable to the hurricane or not? Or if I have a heart attack while I'm cleaning up my house after the hurricane has passed, is that attributable? I think it's very easy to think about, things like drowning more directly as attributable, but I think that gets even more complex when we start thinking about other types of morbidity. So, with COVID, we've seen increases in a number of different unrelated or related but indirect health impacts of COVID, including domestic violence, child hunger, mental health. One of my favorite papers is post-operative complications of appendicitis. Why did more people have post-operative complications of appendicitis during COVID? Maybe because they didn't want to go to the hospital, and by the time they arrived, their appendix had burst. At least that's, what the authors of this paper. Tremendous increases in anxiety and depressive disorder in both household surveys as well as in a number of specific occupational studies and age group studies as well. So reductions in screening and other preventative care. So I know these are more chronic conditions, but we can think about how that may also link to communicable disease as well. Delays in, so this is data from a National Health Service study showing, dramatic decreases, and whether or not all of those losses have been addressed, that reduction gap will still need more time to play out as we see that going on. And one of the things that has been in the news a lot here lately locally, not at all addressing that, but saying that child screening for lead was reduced across the US by at least 40%. Delaware was one of 6 states where it was reduced more than 75% during 2020, and that was ongoing in 2021. So we weren't doing a great job pre-COVID with those childhood screenings, and we're doing a much worse job after COVID. So thinking more about communicable disease, we had reductions in up-to-date vaccine. In most children under 2, this is Michigan data. And again, I know that there's a yeoman's task to do to catch kids up, and that a lot of work is being done on that. But as we think about the longer term impacts of that as related to a disaster that might occur during the time period before people are completely caught up, that can be really important. And so we've seen sort of a interesting example of that with the case of paralytic polio in an unvaccinated person in Rockland County, New York. Subsequently, polio has been detected in 5 New York counties and in New York City. And the wastewater has been genetically linked to that case in Rockland County, and it's also been genetically linked to wastewater in London and Jerusalem. And so I think when we had the case of polio in Malawi earlier in 2022, that case was linked to Pakistan. There was certainly sort of a this could never happen here kind of feeling. I mean, I was teaching outbreak investigation or disaster epidemiology to our students. And, we were sort of thinking about that as sort of like this one case becomes a public health emergency. But the linkages between us all globally mean that at any point in time, it's very easy for a communicable disease to travel. And disasters are, by nature, a kind of displacement accelerator. So whether we think about people just sort of locally evacuating, or whether we think about people, doing sort of a managed retreat and moving to, a completely new location. If we think about humanitarian emergencies and the proportion of people who are at risk as either internally displaced people or refugees, then this, really starts to be something that we have to consider when thinking about disaster. So we can see over the last 15 years between 2000 and 2015, there have been a number of outbreaks associated with disasters and humanitarian crises, and that includes, all of our favorites like measles, mumps, rubella, hepatitis A, B, and E, cholera, tetanus, and so an overall hesitancy or refusal of vaccine that has become more pervasive is something that can very easily come back to affect us in unpredictable ways in a disaster setting. And that goes back to sort of thinking about that situational awareness. Am I working in a community that has falling or, relatively low vaccine coverage? Then I have different types of risks in a post-disaster setting where there may be, again, population crowding, lack of access to safe food and water, lack of access to healthcare. You have a different population at risk there than if your community is highly vaccinated. And so we have a number of major humanitarian crises happening very visibly all over the world. But I think that we could argue that this sort of vaccine hesitancy and refusal is certainly a global problem, but definitely also a US-based problem. And it's something that can really make our public health response to disasters much more complex and important. So I mentioned earlier on about compound hazards as being something that we're concerned about. So this was just some of the disasters that occurred while COVID-19 was also happening. And so, we don't have to belabor this much to say, I'm sure everyone heard about heat waves in Europe last summer, wildfires in the US West, major hurricanes, major Mississippi River flooding. So all of these things are happening at a time when there's an overlap of the types of people that respond to these types of disasters and emergencies and public health emergencies or humanitarian crises as well. So we, seem to be moving towards a future with many more compound hazards and cascading disasters in a situation where the risk factor for many may be changing. And so just as an example of that, We think about the ways that we used to do evacuation, I mentioned. So, you would have to get your measuring tape out to see if you think that these groups of cots are 6 feet apart. Changes were made to the way that we do sheltering, I mentioned, to reduce the capacity of both transportation and shelters and other facilities used in an emergency response. But we also have to, I think, really think about the capacity of responders and response organizations, because again, it's the same people and same groups that are going to be doing these concurrent or cascading responses. And so I think there was a lot of question about, whether we would see spikes of COVID after hurricanes, particularly in the 2020 fall season that was particularly active in New Orleans and Louisiana, I think 4 direct landfalls. And there wasn't in the US evidence of that. Some studies of a typhoon in India and Pakistan did show spikes in COVID infections after a major typhoon. But we didn't particularly see that. So, perhaps some of the types of mitigation that were implemented, I mentioned people getting hotel vouchers instead of going to these types of shelters, so that at least you're sheltering in place with your close contacts already. Thinking about, just sort of other approaches that really shift the way that we think about how we can provide emergency response to people who may be at risk of communicable disease in a post-disaster setting. So lots of lessons learned to identify. I think generally in disaster research, we haven't done a great job of our evidence base. And so unfortunately in July 2020, it was very bad timing, the National Academies released a report about public health emergency preparedness and identified many of the gaps over the last 20 years of response since 9/11 and the anthrax attacks that needed to be addressed. And one was really this idea of the evidence base, being able to demonstrate return on investment. So we've all been in a situation in the last few years, and those of us who've been around for more than one, H1N1 or avian flu, we've seen those temporary funds for surge capacity that, you end up being able to build your general capacity to a certain extent. And when those dollars expire, you're left trying to figure out how you pay for your additional, foodborne or communicable disease epidemiologists that you hired, based on that type of short-term funding. So we really haven't seen the type of sustained investment in the public health emergency response system that we need to really address the gaps that have been identified around even just quantifying morbidity and mortality associated with disasters, much less addressing it. So really understanding what works. Again, that can be very difficult in disaster research, because if you study one disaster, that's just one place, one time, one type of disaster. And the impacts of a hurricane in Florida and Texas and, New York and North Carolina are going to be, the storm itself is going to be very different, and the impacts are going to be different. And we also have what we call in disaster research, this what's called false expectations paradox. And so when people have a near miss and they end up not being impacted by a disaster, they tend to take future threats less seriously. And so that's something else that we need to address. And I know that Kay mentioned I was on the board of scientific counselors for CDC. We just had a 3-day meeting the week before Thanksgiving, and just a tremendous focus in terms of preparedness and response on equity. We would have to be, completely blind not to have seen the sort of intersectional risk that was highlighted during COVID. But I don't think that it was as unique as we would maybe like to think. That has always been the case with, floods and tornadoes and other wildfires and other types of disasters, that social vulnerability and physical hazard, have quite an overlapping set of people at risk. And, we ignore that at our peril. We will continue to pay for things like repetitive loss and, societal inequity through that. And so I think that although COVID has really brought that to the fore, we've known before, and we really have to, understand that that goes far, far deeper than a public health emergency into all kinds of emergency responses. So here's my email. I was super, super happy to see Jamie, who was in our first class of MPH students, on the agenda before me. So I'm happy to answer any questions. I didn't see any pop up in the chat, but let me stop sharing and see if that's